Welcome back, class. We're going to jump into this second segment of the insurance chapter, and we're going to talk for a few minutes about just insurance fundamentals and some of the financial aspects of insurance. First, I want to just take a quick step back, and if you think about whether you want to look at health status or medical care or just overall health care, there really, I guess, three sets of players in the market. You've got the consumers. I'm a consumer, more than likely you're a consumer. I used to work for a health plan. I work for providers. So you've got consumers, kind of one of the players in the market. You've got payers, another player in the market. And then you've got your provider community as the other player in the market. So there can be some other minor players in the market, but those are kind of the big three. And if you go back to your old micro classes and kind of think through this, what are consumers, and it doesn't matter, it's not just healthcare. What are consumers trying to maximize? It goes back to self-interest. What are consumers trying to maximize? They're trying to maximize the utility, the benefit, the satisfaction of seeking either building their health status, reducing the depreciation on the health status, seeking medical care. And so they're going to continue these strategies or these activities, again, until marginal benefit equals marginal cost. And at that point, they're going to stop. If marginal cost is greater than marginal benefit, they're probably not going to want to do it. If marginal benefit is greater than marginal cost, they'll continue doing it until those two equate. And then, so that's your consumer. And if you think about the payers, it's a similar concept. Marginal benefit, they will continue to provide healthcare goods and services to their membership, to their consuming population, as long as until that point that marginal benefit equals marginal cost. And remember, on the health plan side, they may not want to admit to it, but they are there to make a profit. Doesn't matter whether they're not for profit or for profit, health plans want to make a profit. And so they're going to continue to provide those services until the marginal revenue equals the marginal cost. And then lastly, think about the providers, just like the health plans. They can be not-for-profit group, they can be for-profit, but it doesn't matter. They're there to generate a profit. They're there to make sure that the revenue they take in, minus all expenses, leaves something that they can utilize to move forward. Maybe as an investment, maybe to put in some kind of an equity account, but providers are there again to generate, to maximize profits. And similar to the health plans, they're going to continue to provide goods and services either directly to payers or maybe directly to private pay individuals that maybe don't have a health plan. They may be providing those services to a government health plan like TRICARE or Medicare or Medicaid. But again, they're going to continue until that point where marginal revenue equals marginal cost. So it doesn't matter which of these three, which of the big three players that you have in the medical care market. All of these players are maximizing. All of these players are trying to maximize some type of utility function, whether it's just basic utility or it's maximizing revenues. And that's the one thing that kind of draws these three groups of players together. And with that, we're going to jump into just insurance fundamentals. And as we've talked in the past, insurance assigns risk. And they have, it's basically the assignment of risk to a third party, that third party being an insurance company. In this case, they assign risk. They can pool it over critical mass. They can generate premiums. Premiums are in most cases, the monthly amount that employer groups pay to cover their employees, maybe the monthly amount that a health plan gets from a government agency, like Medicare Advantage, or maybe they're providing services to Medicaid or TRICARE. So maybe they're getting that monthly premium, or maybe you're just buying private insurance and you walk into the health plan, you pay them on a monthly premium. So that premium is based on what the expected payout is going to be. And when I say the expected payout, that's how many dollars the health plan is going to pay the providers to generate medical services, medical care for a covered population. It's also going to cover administrative work, medical management, network management, payment integrity. Health plans have a lot of individuals working kind of in this administrative side. Health plans also, in most states, are required to keep a reserve fund in case of some kind of catastrophic event that, states don't want, or federal government, either one, doesn't want a health plan to go belly up. So there are some reserve funds that have to be collected and then set aside. And then lastly, if there's anything left over, it's considered profits. And so the premiums that the health plan receives really exceeds the fair market, or the fair, I'll call it the fair market value, or the expected value of accepting risk. So you look at, actuaries, again, in a back room somewhere, have calculated what the expected payout is, and that may be considered by some to be the fair value of transferring that risk. But there are other things tacked onto that to ensure that a health plan is actually making money. And some things that you'll hear, especially in the news, when it comes to health plans, they will talk about, and you'll hear terminology talking about medical loss ratio. So medical loss ratio, in the simplest of terms, it's the dollars that a health plan pays out divided by the dollars that they bring in. And health plans, at least historically, have set that medical loss ratio. Most of them set it at 85%. You have a few that set it down in that 75 to 80% range, but sometimes it gets extremely difficult to hit that 75, 80% medical loss ratio. And so anything above that medical loss ratio is considered what they call a loading fee. It's a portion of the premium that exceeds, as we talked about, the fair market value. It's the price of insurance, the cost of transferring risk, and it's a percentage of the premium and the payout. And again, the payout is the dollars that the health plan pays out for your to cover you for healthcare services, and typically that's considered the medical loss ratio. Insurance suppliers will enter the market, and they'll enter the market based on what they think the estimated payouts are going to be, what they think the degree of risk is for a given population, what they think the probability of risky events. You have some health plans that will enter a market, and they may be in the market providing healthcare goods and services for, say, a year, 2 years. They're not making a profit, and they'll pull out of the market. They will could discontinue providing healthcare goods and services to a population in a given market, maybe a region, maybe a state. But health plans go into a market thinking that they can turn a profit, and they have a time horizon. They know they're probably not going to turn that profit maybe in the first year, maybe the second year. But by the time they're hitting late second year, early third year, most health plans are expecting to turn a profit. And when you talk about, there are two ways that health plans, at least the terminology that you'll hear, two ways that health plans approach and what I'll call fully funded types of health plans. And one's experience rated, and it's more along the lines of economists will talk about time series data. Property and casualty does it, healthcare does it, and it's based on experience, time series data and experience, based on, just like with healthcare, they're typically broken out into age, sex cells. So you'll see, if you've ever seen an actuarial breakout for healthcare, it's basically two columns, and at the top of one column, it'll maybe say age category, and at the top of the other column it'll say sex category, and it'll start going down through there, and it'll have maybe 0 to 2 years old, male and female. And for each one of those categories, each one of those cells, it's going to have a dollar value that the actuaries have calculated that they think it's going to generate either on a yearly basis or on a monthly basis. And that's experience rated. The flip side of that is you hear the term community rated, and it's more cross-sectional data. And it's usually for some smaller groups that don't have the critical mass that actuaries feel comfortable about allocating or estimating the payout from. And basically what happens is, you bring a group of small companies together. When I say small, companies with smaller populations or smaller members, and they'll put them all together in a pool. And it builds the critical mass that actuaries are comfortable with. And actuaries will actually estimate the premiums based on, that's why they call it community rated. It's across multiple families, across multiple employer groups, and they're rating them together because the employer groups themselves don't have enough critical mass that actuaries feel really that comfortable in trying to estimate payouts. And then lastly, kind of before we leave this piece, want to just think about when we're talking about insurance, it can be healthcare, it can be what you call P&C, property and casualty. Typically, you think property and casualty along the lines of automobile insurance, homeowners insurance, maybe business insurance. Those are kind of property casualty type. There's life insurance, and if you've watched TV, you'll hear maybe it's Colonial Penn. I can't remember the insurance company, but Jonathan comes on, and he's selling insurance, and for as little as $9.95, if you're over 55, and for $9.95 a month, they're going to give you health insurance, and they don't care, if you've got pre-existing conditions, they don't care what your medical conditions are. But they have with actuaries, they have estimated, again, age, sex, sales, and they know they have estimated, the probability of how long you're going to live. And if you pay attention to the TV ads down at kind of I think it's Colonial Penn, down in the fine print, it says something about there won't be any payouts for the first 2 years or something. I can't remember how it's worded, but basically that's why they don't care whether how sick you are, what kind of your pre-existing conditions are, because they're not going to, even if you die within the first couple of years, they're not going to pay out anything anyway. And they also say that as long as you continue to make the premiums, they're not going to cancel you. And, that makes sense because they want those monthly premiums to continue rolling in. That's how they make their profits. And then lastly, before we kind of leave this high level discussion of insurance, most employer groups, you will see when you sign up for health insurance, they usually have it broken into 3 categories. Single plus spouse, and family. And so if you're a single individual working for a company, or even if you have a spouse or a partner, you may elect to take insurance with your employer as a single individual because your partner or spouse may have insurance with the individual that they work for. And likewise, some companies will actually, if you've got a spouse or partner with insurance at another company, they will actually pay you maybe $100 a month not to take their insurance. So that's basically what's single. And then, I think single plus spouse or partner is pretty self-explanatory. And then what you have on a family is where a lot of individuals working for a company get a little crossways, because basically based on the premiums or out of the pocket that you have to pay to elect to take health insurance with your employer group, you are actually the singles and the singles plus spouse, you're actually subsidizing the families, because families can be, a single and a spouse and 1 child or 2 kids or 3 or 4. It doesn't matter. It's considered a family policy. So a lot of times what happens is those of us that are single, or those of us that it's just, you're yourself and your spouse or partner, we're actually subsidizing a lot of the healthcare goods and services that these families are consuming. And then going to spend just a few minutes talking about moral hazard. And moral hazard is described by different definitions, but it's the behavior impacted by insurance companies. Careless with property, overutilization, and excess demand. And what I've always normally thought of moral hazard, it more along the lines of you buy automobile insurance. And your automobile insurance says, in the event of if your car is stolen, we will, provide you full replacement costs to secure another vehicle. Well, moral hazard basically means, hey, I'm going to get out. I'm not going to lock the door. And if somebody steals my car, the insurance company's going to pay for it. Why do I care? Or you have homeowners insurance. And with your homeowners insurance, you leave you leave the front door unlocked. You don't install security cameras. You leave your, valuables out where somebody can come in and steal them, because at the end of the day, what do you care? Insurance company's going to replace them. So, and then when you think about healthcare, it's along the lines of overutilization. Individuals that, just like myself, so I know my benefit plan with my health insurance company, I've got a $10 copay. Every time I go to the doctor, $10. I can go every day if I wanted to, $10. That's all it's going to cost me. And it sets up overutilization. So I might not need to go to the doctor, but I look at it and says, hey, I've already paid my premium. I'm going to take advantage of this. Same thing with pharmaceuticals. You'll have individuals that will continue, especially maintenance type drugs, will continue to have those prescriptions filled, whether they need them or not. And some individuals will actually fill the prescriptions and sell them on the black market. So that's what we're talking about moral hazard. And it is a significant issue, both in property and casualty and in health insurance. And what we talk about healthcare, it reduces the cost of adverse events for individuals in healthcare. And it's a little, I don't want to say weird, but if you compare healthcare to property and casualty, typically healthcare is paid on a monthly basis. Your employer group sends a check or sends an electronic deposit to the health plan on a monthly basis based on the number of employees that company has. If you think about your paycheck and your company, I'm assuming you have to subsidize or have to pay something out of pocket for your health care. Some companies take it once out of a monthly check. Some take it out of every other check. Depends on how your company has it set up. But if you think about property and casualty, think about how often, I pay my homeowners insurance once a year. I pay my automobile insurance every 6 months. And so that's the difference. It's a difference between property and casualty and healthcare. One of the main differences is it's just the payment schedule. It's a little different. It's just a different sequence or scheduling of payments. The other thing that's the difference between property and casualty and healthcare is property and casualty pay for, I'll call it episodes or adverse events. So property and casualty, you have water damage on your home. There's going to be a fairly significant deductible. They're going to make you a lump sum payment for that water damage. If you have a wreck in your automobile, it's going to be, a lump sum payment for that wreck in your automobile. If you have health insurance, so property and casualty is experiencing almost one-time cost they're experiencing one-time cost for each event. Whereas health plans, if you think about the way that they pay providers, I go into my doctor's office and I tell them I think I've got pneumonia. So, the health plan's going to pay for that office visit. They may pay for some lab work, radiology. They may want to, do an X-ray of my chest. Probably going to pay for some pharmaceuticals, and they're actually going to pay for multiple office visits if needed. So it's just a different way of money coming in to the either property and casualty healthcare, and money going out the door between property and casualty and healthcare. And what happens with what actually happens when you have health insurance, there's a shift in demand, because health insurance, for the most part, with most individuals, again, I'm starting to sound like an economist, for the most part, and with most individuals, it's going to shift the demand for healthcare services. Again, how far it shifts that demand is going to be based on what your individual benefit plan includes. Is it coinsurance? Is it deductible? Is it copay? Is it high deductible plan? I mean, there's a multitude of these benefit plans that either you buy directly from the health plan, or your employer group has purchased for you and they set it up. And you as an individual, for the most part, you may have a couple of options on health plans, but you typically don't have options among health plan providers. So in other words, you may have multiple options on benefit plans from a given health plan, as opposed to multiple health plans providing a benefit to your employer group. And the last thing to just kind of quickly address is, where you talk about property and casualty, you're thinking more of catastrophic events. Again, flood damage, automobile wreck, tornado, hurricane in Florida, earthquake in California, forest, not forest fire, but wildfires in California, or wildfires on the West Coast. Those are catastrophic events, and that's why you have property and casualty. Healthcare, it's a little different. They're paying for catastrophic events, cardiac procedure, neurological procedure, you're involved, some catastrophic event where you hurt yourself at home, maybe in a car wreck. With the car wreck, it gets into motor vehicle accidents, and then you're talking about, comparing benefit plans. That gets a little dicey, but they also pay for routine events, annual wellness, wellness type, events to help improve your health status, routine doctor's visits, laboratory work, pharmaceuticals, radiology, surgical procedures, ambulatory surgery, home health. They pay for a lot of routine type events, and many of them are highly predictable, and a lot of them are low cost events. With property and casualty, you typically don't generate that many claims in a year. If you're generating a lot of claims in a year on a property casualty like homeowners or automobile insurance, you're not going to be with them long, because they're going to drop you because you are too much of a risk for them. With healthcare, there's just a lot. I mean, just think about how many times you go to see the doctor in a year. You may go to see the doctor, I don't know, half a dozen times in the year. And they're going to be low cost, for the most part, low cost events, but there's going to be several of them. So that's one of the other differences between property and casualty and healthcare. Healthcare is paying for a lot of events as you go forward over a year's time. And then we're going to talk a few minutes about kind of some of the other financial aspects of health insurance. We're going to talk about deductible. And if you think, and again, I'm using a comparison between property and casualty and healthcare, think about your deductible on your car insurance. $500, $1,000, $2,000. What that deductible says, you have to pay out of pocket for that first, whatever the deductible is, $500,000, $2,000. And then at that point, your automobile insurance kicks in. If it's homeowners insurance, it may be a deductible like that, or it may be a percentage. Maybe your deductible is 1% of your home value or something. But there's a deductible built into those property and casualties, for the most part, type of insurance policies, and you have to pay that deductible before the insurance starts kicking in. With healthcare, there's also can be a deductible, but it's typically a yearly deductible. And what you have on those yearly deductibles is once you hit that yearly deductible, then the health plan kicks in. So let's say your yearly deductible, you see things like $2,500 for an individual or $5,000 for, a family. So once you generate expenses or payouts from the health plan that hits those deductibles, then the health plan kicks in. Whereas on property and casualty, it's more of a event by event type of deductible, whereas health plan, it's more of a yearly deductible. It's a cumulative over a year's time. And it impacts your moral hazard, and it also impacts end of year spending. So when I say end of year spending, what you see a lot of times is, depending on when the fiscal year ends, and in most private insurances, the fiscal year runs from January the 1st to December 31st. If you're the government, the financial year runs October the 1st to September the 30th. And what you will see a lot of times is individuals that have met those deductibles. Well, actually, let's say you've met your deductible in September. Everything that you generate on healthcare expenditures from the health plan, from the day you hit that deductible until the end of the calendar year or the end of the fiscal year, depends on how you want to call it, how it's set up. The health plan is kicking in and helping you pay for it. So you will see individuals, especially in government base like Medicare and TRICARE, they will generate just a lot of claims at the month of September, because they're trying to beat that yearly deductible that they've already hit and trying to get everything they can pushed into that fiscal year. Private healthcare insurance is it's similar, but you see the same phenomenon, but it usually happens in December. Everybody's trying to get their eyes checked. They're trying to get as many pharmaceuticals as they need refilled. So there's this, I don't want to say mad scramble, but you see a significant uptick in some of these healthcare goods and services as you come down toward the end of that fiscal year. And then let's talk about coinsurance. Coinsurance is a portion of the total expenditure paid by the insured and mitigates the moral hazard. Depends on how it's set up. You could have maybe in place of a deductible, you just have to pay for every service you receive, you have to pay 20%. I think traditional Medicare is 20%. And what coinsurance does, same thing deductible does, but more so probably in coinsurance, it helps mitigate that issue with moral hazard, because health plans feel like that if somebody knows they have skin in the game, they're going to have to pay a certain percentage every time they take advantage of their health benefit plan, then it actually reduces the desire or the incentive to overutilize or move that or shift that demand curve and increase the demand for services. You sometimes see what they call usual and customary fees. Typically, it's health plans use them when you're what they call out of the network. So if you have a health plan that just covers, let's say, state of Tennessee, you have a health plan that just covers the state of Tennessee, and you're traveling and you need healthcare services, and maybe you decide to go to Vegas. You decided to go to Vegas, and you get sick while you're in Vegas, which I think it happens fairly frequently in Vegas. So you get sick while you're in Vegas for one reason or another, and the health plan in Tennessee may not have providers contracted in Las Vegas, and what they'll do is they have a national schedule that's called usual and customary, and they may have one for the state of Nevada too, and they work an agreement with providers in Vegas that they'll pay usual and customer charges for any services that you receive while you're in Las Vegas. So one thing that you'll see, and it's becoming more and more frequent, has been a shift not only, but mostly in the physician side of medical care, it's shifting from fee for service. So fee for service, fee schedules, to negotiated rates, to what they call capitation, where they determine that for every member that you as a provider is willing to take of the health plan, they will pay you what they call a per member per month. So actuary has developed this per member per month fee schedule, or per member per month value, and it's all based on, as I said, age and sex cells. And so you as a provider, you agree that you'll service their members and for this per member per month. And then there's also, it's moving into what they call value-based. You'll hear this value-based terminology, and it's somewhat similar to capitation in that they are going to pay you a prospective payment for a bundle of services. If you're a primary care doc, they may say, well, there's about 50 what they call evaluation management codes that they will pay you a monthly fee to see all of their patients that are linked to you and in their system, and they'll also pay some extra dollars if all of the percentage of, based on the percentage of members that have their annual visits and get their vaccinations and a lot of these ancillary type services. So, but they're trying to, through these different types of reimbursement strategies, trying to ration or control the overutilization and overspending of healthcare goods and services. And one couple of other just quick comments is, you've got managed care organizations. You'll see an acronym MCO, but it's a managed care organization, and they manage and ration services through like primary care physician or primary care manager. So basically you're signing up with Dr. Smith, and maybe you can't see anybody but Dr. Smith unless Dr. Smith gives you a referral or an authorization to a specialist. Health plans sometimes use what they call pre-certification. So you have to get a pre-certification to go see a provider. They have structured and tiered provider networks. And if you'll go to this provider or this group of providers, maybe the benefit plan that you have as an employee of a company, it's a $5 copay. And if you go to this network, they want a $10 copay. And if you go to this network, it's a $25 copay. So they built all of these tiered networks because they think the networks, I guess it's loosely based on the perception of quality, but it's more likely based on some type of a utilization metric. And so basically what they're doing, they're trying to manage the supply side. They're trying to manage the supply side of healthcare goods and services. There's some stop loss provisions built into to limit the liability of the insured. So you can have, especially an employer group, and especially what they call ASO group. So that's an employer group that has decided that they don't want to pay a premium. They're just going to pay an administrative fee to a health plan to provide them a provider, to give them a provider network, give them some, or develop some medical management for them, process their claims, and they're going to take the risk for all of the healthcare that their employees generate. And they view it as they have the capability to be more efficient than a health plan does. And some ASO groups do. But to cover themselves from like catastrophic events, they go out and they buy what they call stop loss. And a lot of health plans that you will see that, especially if it's what they call, go back to the fully insured that I said was either experience rated or community rated. And that means if it's fully insured, that the health plan has some skin in the game. And the health plan, when they've got skin in the game like that, they're concerned about adverse selection, individuals with above average health related characteristics, excessive chronic adverse conditions, asymmetric information. And again, it goes back to where we've talked in the past about asymmetric information. It's a basis for risk. And that's the rationale for a single payer system. You hear congressional leaders and policymakers talking about, oh my God, let's get rid of all of these health plans and let's just go to a single payer. If we went to a single payer, we would have all of the information available on Mr. Smith, because over the years, Mr. Smith has worked for Company A, and they may have had United Healthcare, and he left and went to Company B, and they had Aetna, and he left and went to Company C, and they had Centene, and he goes to Company D, and they've got some little regional plan. And a lot of these health plans don't share a lot of information back and forth because they don't want anybody to know what they're doing. Because if you start sharing healthcare information, if you're just even an average analyst, you can take that healthcare information and you can look at individuals' deductibles or individuals' coinsurance or copays, and you can look at bill charges and what the allowable amount was, and you can actually figure out what the contractual rates are for these health plans with the provider group. So health plans they're not going to share a whole lot of information. And because it is so, as Dewara talked in her first chapter, I think, talked about health plans, healthcare being dysfunctional. And I think that's what she's getting at. A lot of different payers aren't sharing information. And as members pass from one health plan to the next, there's all of this asymmetric information that's flowing in that direction. Insurers engage in positive selection. They like to market to which population? I mean, think about it. Younger, healthier, low-risk population. Younger, healthier, low risk. That's where you make your money in health plans. You don't make your money in high risk, especially jobs that have a high risk factor, that goes with them. You also, there's certain regions in the country that have risk factors. Think of the coal mines in West Virginia, Eastern Kentucky, East Tennessee. There's just a lot of high risk factors that go with individuals in those populations. So health insurance, they're going to make their money by again, marketing to certain, and the actuaries have told them which markets to market these health plans to. And as I said earlier, health plans will move into a market, set up shop, and if they're not making money in 2 or 3 years, they'll just close up shop and move to the next one. And that's going to wind us up kind of with the insurance fundamentals. We're going to come back in a few minutes, and we're going to talk about, I'll just call them just some, I don't want to say a mishmash of health insurance, of healthcare insurance topics, but mishmash in such a way that hopefully I can tie it together for you. So with that, I'm going to end up this second segment, and I'll be back and we'll touch base on that in a few minutes. Thanks for joining.